Any person aged 65 years old with normal blood pressure has a 90% lifetime risk of developing hypertension. Isolated systolic hypertension is the most common form of hypertension in the elderly. Isolated systolic hypertension is defined as systolic blood pressure is more than 140 and diastolic pressure less than 90 millimeters of mercury. Isolated systolic hypertension, in the most cases, develops as a result of decreased arterial compliance, which means the volume of arteries remains same because the loss of elasticity, and it causes big gap between systolic and diastolic pressure. This is commonly seen among the elderly as there is increased deposition of calcium and collagen to the arterial wall and arteries lose elasticity. In most cases of systolic hypertension is primary, rarely attributed to other causes of secondary hypertension such as hypothyroidism and aortic insufficiency. Risk factors for isolated systolic hypertension can be intake of nonsteroidal anti-inflammatory drugs, steroids, sympathomimetics, cocaine, and intake estrogen. Smoking, diabetes, dyslipidemia, obesity, sedentary lifestyle, unhealthy diet, and alcohol intake. Family history of hypertension, renal disease, diabetes, or cardiovascular disease. Active treatment of isolated systolic hypertension in older adults resulted in significant reductions in the all-cause mortality. That's why treatment is important. First-line treatment is thiazide-like diuretics and calcium channel blockers because they're reducing the risk of stroke and other morbidities in patients with isolated systolic hypertension. Angiotensin-converting enzyme inhibitors and angiotensin receptor blockers is often used in the patient with heart failure, reduced ejection, post-myocardial infarction, diabetes, or chronic kidney disease. A combination of either angiotensin-converting enzyme inhibitors or angiotensin receptor blockers with calcium channel blockers or a thiazide-like diuretic can be considered. Beta blockers are less effective in the management of isolated systolic hypertension. The goal blood pressure of less than 130/80ths of a millimeter of mercury is appropriate as long as the patient tolerates it. Among elderly, less than 140/90ths of a millimeter of mercury is considered reasonable in patients who are in the elderly population and patients with labile blood pressure, or to avoid polypharmacy. Patients who receive antihypertensive treatment may precipitously drop their diastolic blood pressure as well. As myocardial perfusion occurs mainly during diastole, an excessive drop in diastolic blood pressure may increase the risk of cardiovascular disease and death. Recommended for all patients, regardless of the reading of the blood pressure. Restrict dietary salt, aim for 1.5 grams or less per day. Weight loss, every 1 pound or 0.45 kilograms of weight loss will result in a reduction of 1 millimeter of mercury blood pressure. Rich in fruits, vegetables, whole grains, fish, and low-fat dairy products. Diet helps to reduce blood pressure by an average of 6/4 of a millimeter of mercury. Increase physical activity. Aerobic and resistance training can reduce blood pressure by an average of 4/3 to 6/3 of a millimeter of mercury irrespective of body weight. Limit alcohol intake to no more than 1 alcoholic drink per day for women and 2 for men. Take a potassium supplement, unless contraindicated in chronic kidney disease patients. Quit smoking.